This session is sponsored by Roche, and our speaker is Dr. Ankur Punia, medical oncologist from Jaipur. So I invite Dr. Ankur to please deliver his talk. Over to you, sir.
Slides are not coming here. Yeah, good evening everybody. Thank you for inviting me to this talk. So today I am going to talk about cancer immunotherapy, particularly the role of atezolizumab in second line non-small cell lung cancer. The slides are not changing from here on the screen. The slides are changing in the laptop, but they are not updating here. They are still not changing.
You change the Take a track, please.
So lung cancer is basically a leading cause of cancer mortality worldwide. If we see the Globecon 2022 data, it's the second most common cancer in the world and the number one cause of cancer mortality. So in India, the incidence of lung cancer is number 4, but still the mortality is very high. So if we see lung cancer, most of the patients, even this is the SEER database, which shows that 80% of patients presents with stage 3 or stage 4. Around 30% patients present with metastatic disease, which might be, I think, even higher in the Indian setting. I will say around only 10% patients present to us with an early case setting, and those two might be the referral centers where they have a good enough surgery department. They might be seeing a higher number of early cases rather than the centers in the tier 2 or tier 3 cities. So 5-year overall survival, if you look at all the lung cancer patients, still at low at 20% from stage 1 to stage 4. So now we have multiple options for metastatic lung cancer patients who doesn't have any actionable driver alteration. We have multiple combination upfront chemotherapy, immunotherapy plus chemo plus VEGF inhibitors, and in second line we can switch based on whatever the line was used in the first setting. So for the patients who has used first line immunotherapy combination, we don't usually use in the second line, and second line we use immunotherapy for the patients who has not received vice versa in the first line. So now we are particularly looking in the patients who are in the second line setting who has used some kind of chemotherapy in the first line. So this was the pivotal study for the nivolumab, which the first study, checkmate 57 and 17, in which they randomized versus nivolumab versus docetaxel. And at the primary OS, we can see a significant benefit of using in either squamous cell or an adenocarcinoma, almost 3 months benefit compared to docetaxel. And if you look at the 2-year also survival, there was almost a 10% difference in the non-squamous cell and almost a 15% difference in the squamous cell cohort. So immunotherapy has good results in the second line, and this was shown irrespective of PD-L1, particularly for squamous histology, whether it was less than 1, more than 1, or any type of combination perturbation they tried, but still the benefit was there. But for non-squamous, in the PDL low patients, the benefit was not there. It was particularly more, we can see whether they were more than 10%, 5% or 1%. It was more for the patients who had higher PDL1 compared to the low PDL1. Now looking at atezolizumab in this particular setting, Poplar was a phase 2 study, and eventually the OAK was the phase 3 study which they did. They took patients who had received 1 or 2 previous line therapy, and irrespective of PDL1 they took the patient randomized atezolizumab versus docetaxel. And we can see there was significant OS benefit which was same as seen in the checkmate study, around 14 versus 9.6 months. And this benefit was seen irrespective of PDL1, whether it was high TC3 or TC0. There was still a significant benefit, though the benefit increased as the PDL1 level increased, but still the benefit was there. Even at 2 years, there was almost a 10% difference between the overall survival in this particular study. And if you're looking at the depth of response also, depth of response was also markedly increased, irrespective whether PDL1 was used or not, PDL1 was high or low. There was significant duration of response when immunotherapy was used. This was one of the case of the study which shown a very good response. Even at 3 years, patient was almost in complete remission. So looking at in particular the mutations, for patients who had a KRAS wild type or mutated, the benefit was there. But for EGFR mutant, which we know now that immunotherapy doesn't work, particularly in actionable mutations like EGFR, so the benefit was not there. But it was still, for KRAS mutated or wild type patients, benefit was there of using immunotherapy. If we look at the other subgroups, for smokers or previous smokers, even for patients who had baseline CNS mets, and also patients above 65 years of age, the use of atezolizumab showed a benefit compared to chemotherapy. In OAK, a second thing was that the patient could able to continue atezolizumab after there was a radiographic progression. So if patient who has progressed radiographically as per ASSIST, but they can be allowed to continue if they had a good clinical benefit as per the investigator, or they didn't have any signs, symptoms indicating, unequivocal disease progression, or they had a decline in ECOG PS, no any significant critical site involvement like leptomeningeal disease. So in those patients, they were allowed to continue on atezolizumab beyond the radiographic progression. And we can see the patients who used atezolizumab beyond progression, almost 7% again had some response, PR was there. Around 50% patients had stable disease and 43% had progressive disease. So patient who had used beyond progression, still the benefit of adding atezolizumab was there with around 12.7 months compared to other cancer drugs which were used, in which OS was around 9 months. There was a difference at 18 months of almost 17%, which was significant for this trial. And these curves remain separated. Even those patients who received post-progression immunotherapy, almost 60% of the patients in docetaxel arm received immunotherapy eventually, but still there was a significant difference in the OS at 18 months. The updated 4-year survival was shown at ESMO 2020 in both the Poplar and the OAK. It continued to show that even at 4 years, there was a significant difference of around 7% in the patients using atezolizumab. And this benefit was seen irrespective of whether it was squamous or a non-squamous histology. So the benefit was more in adeno compared to squamous, and benefit was irrespective of PDL1, whether it was high or low. Again, this shows the same thing. The patients with PDL1 high TC3 or IC3, they had a remarkable difference in the around 33 versus 15% at 4 years. And even with patient with PDL1 low, there was around 8 to 9% difference in both these studies. And looking at via histology, though the benefit was more in the non-squamous cohort, but still the squamous cohort also continued to show benefit of around 7 to 8% at 4 years. So the patient eventually who, at 4 years, who survived at 4 years, we can see that most of these patients received subsequent therapy. Around 80% of the patients in the docetaxel arm received subsequent therapy, and 40% in the atezolizumab received immunotherapy, received subsequent therapy, and around 65% patients in the docetaxel arm received immunotherapy. But still there was good difference at 4 years. And looking at this, the patient who responded among patients who survived for more than 4 years, you can see that almost 50% in the popular study and 3 out of 4 patients in the docetaxel arm were responders. In OAK study, almost 50% in the arms, in the atezolizumab, and around 40% in the docetaxel arm were responders. So even though patients who had, almost 40% patients who had stable disease or progressive disease, still they continued to respond at 4 years, even though had best response as stable disease. And the same thing we can see here. And looking at the side effect safety profile, there was not any significant, increase in any IR related or serious adverse events at 4 years, and they were as which we have seen in all the studies of immunotherapy. So the long-term findings showed that the popular and the OAK study that 4 years suggest a consistently greater survival benefit of using immunotherapy, and even if the majority of patients in the docetaxel arm, around 65%, received immunotherapy, and radiographic response is not a requirement for a long-term survival benefit, as around 20-30 patients who were alive at 4 years in atezolizumab arm had the best response as progressive disease. So atezolizumab showed a consistent and a manageable safety profile, and no new adverse events were seen. So based on this, atezolizumab is used in second-line setting irrespective of PDL1 and irrespective of histology. Now looking at this TAIL study, which is a global single-arm safety study of atezolizumab monotherapy in all kind of population who has patient received 1 or 2 previous lines of therapy. So basically it included all those patients who has received 1 or 2 lines of therapy, and they might have received some previous checkpoint inhibitors. They should have untreated asymptomatic CNS metastasis, even patients with ECOG PS2, any active or chronic hepatitis B or C, any severe renal impairment, even of patients of autoimmune disease. As we can see, almost 10% patients had PS2 in this study, and around 6% patients had received some kind of previous immunotherapy. Around 6% of patients have EGFR ALK mutation. Around 14-15% patient had a CNS metastasis, and 5% 3 patients were history of autoimmune disease as well as active chronic hepatitis infection. Adverse events were more or less seen, which were consistent with any kind of safety profile which we have seen in other immunotherapy trials. If you look at the adverse events were slightly more. If you see any kind of adverse events, they were almost similar. If you see any patient with CNS mets, renal impairment, ECOG PS, even the patient who has prior PDL1 or autoimmune disease. Though grade 3, grade 4 events were slightly higher in the autoimmune patients, but they were still manageable. There is no increase in grade 5 adverse events compared to the standard population in any of these subcohort. And leading to discontinuation was higher in the autoimmune disease because of slightly higher number of adverse events seen in these patients. So if you look at the overall survival, it was 11 months in this study, and for the patient who had an OAK-like profile, or if you see the OAK trial inclusion criteria, it was 13.7 months. So it's almost similar if we compare to the OAK study and this real-world study. And if you see the efficacy-wise, in patient who had OAK-like population, patient even had renal impairment, in patient with autoimmune disease, results were good. Patient with CNS metastasis, PS2, and who has previously received any immunotherapy, this OS was still not that much better by adding this immunotherapy. It was around 5 to 6 months, and in other population it was almost more than 10 months. And this efficacy was seen irrespective of PDL1. When PDL1 positive or negative patient, benefit was there, so slightly more in the PDL1 positive population, and in PDL1 negative population, in all patients it was not significant, but in OAK-like population it's still a good survival was seen of around 11.7 months. Patient who had a PDL1 unknown, there was not any significant difference. So this was updated tail analysis in this year, which showed that at 36 months, around 20% patients are alive. And if you see the OAK-like, if you see the OAK inclusion criteria, around 25% patients are alive at 36 months, at 3 years. So if you look at the different subgroups at this updated analysis, again all kind of patients benefited except for the patient with CNS mets, patients who had liver metastasis, any kind of autoimmune disease or prior immune therapy. All other subgroup received irrespective of histology and received some kind of benefit by adding atezolizumab. So if you look at the summary of the study, it showed confirmed the safety profile of in a diverse previously treated NSCLC population although it's not powered to draw conclusion from each subgroup, but it provides us some information, ideally which subgroups can be excluded, which are usually excluded from clinical trials, like the patient with renal impairment, active infection or autoimmune disease, which are excluded from all of the immunotherapy trials. And these data are generally consistent with the published data of any checkpoint inhibitors, which are used especially in tests like ECOG PS2. Furthermore, the novel data on the use of atezolizumab is more diverse population, like I already told you. So particularly looking at this autoimmune disease subgroup analysis, there were around 30 patients who had an autoimmune disease. So looking at the adverse events in this particular autoimmune population, immune-related adverse events were on the slightly higher side. Particularly, we see GI side effects were higher, and pneumonitis was higher in this subgroup. It's around 13% pneumonitis, and like these GI side effects like appetite, nausea, these were higher in this subgroup autoimmune patients. If you look at the efficacy wise, it was good, around OS of 10 months and a PFS of 3 months, which are almost similar to any kind of patient who doesn't have autoimmune disease. Response rates were almost similar. So it can be used particularly in patients with autoimmune disease who have a controlled disease, basically, not an autoimmune which is not in control and has flare up of disease. With a moderate increase in adverse events, particularly respiratory or GI, but they may help us to include these patients for eventual treatment by using immunotherapy. So by looking at the overall summary of all this OAK and TAIL study in the second line setting, atezolizumab has demonstrated a good benefit versus docetaxel in previously treated irrespective of histology, irrespective of PDL1, and even subsequent immunotherapy. A clear OS benefit was seen with atezolizumab. TAIL study, which is a real world, based on more like a real world study, showed a survival benefit in multiple subgroups which were typically not included. And safety wise, there was no any newer side effects or long term immune related side effects which were seen, which we have not seen previously. So based on all this, atezolizumab is now recommended as a second line treatment for a patient who has not received immunotherapy in the first line. Thank you.